I'm Bruce Copeland, and I'm an attending physician with the Cardiac Arrhythmia Service at Brigham and Women's Hospital. This lecture will be on the topic of cardiac conduction system disease. The objectives of this section are to understand the different manifestations of sinus node dysfunction, to understand the different types of atrioventricular block, to have an understanding of the indications for pacemakers in patients with conduction system disease, and to understand unique situations involving conduction system disease. This slide shows a schematic of the normal conduction system of the heart, with electrical activation originating in the high right atrial area of the sinoatrial node, and conduction passing through the atrioventricular node and then to the right and left bundle branch. As we will see in today's talk, the level of abnormality within the conduction system can affect the prognosis of cardiac conduction. This slide shows an intracardiac recording of the normal conduction system taken from a diagnostic electrophysiology study. The first 1, 2, 3, 4, 5 tracings show the surface cardiac electrogram, and you can see the QRS morphology here. The next tracings are taken from a high right atrial catheter recording an atrial electrogram, and this tracing below comes from a catheter placed across the tricuspid valve where it can record a signal from the atrial electrogram, followed by the His bundle electrogram recording, followed by the ventricular electrogram recording. The His bundle electrogram recording is obviously not something that can be seen on a surface EKG, but with this intracardiac recording technique, one can observe the timing between atrium and His and the ventricular electrogram. And in this way, it can be determined if there is an abnormality in the AV node or below or at or below the level of the His. A normal HV interval is 35 to 55 milliseconds, and a normal AH interval is 60 to 120 milliseconds. The recording at the bottom is recorded from a right ventricular apical catheter, and this is therefore a ventricular electrogram recording. As an aside, if a patient has a dramatically abnormal HV interval found incidentally at electrophysiology study, an HV interval of greater than 100 milliseconds, there is an increased risk of progression to AV block and asystole, and a pacemaker should be offered, even in an asymptomatic patient. In a patient with syncope, felt suspicious for conduction system abnormality and an HV interval of greater than or equal to 70 milliseconds, a pacemaker should be considered as well. We will first talk about conduction system disease at the level of the sinus node and above the AV node. Sick sinus syndrome is a term given to a group of arrhythmias that result from dysfunction of the normal pacemaker of the heart, the sinus node. This can, various categories of sick sinus syndrome are shown on this slide: sinus bradycardia, sinus arrest, or sinus exit block, the latter of which results from electrical activity in the sinus node being unable to exit to the atrium to affect conduction. Chronotropic incompetence, which refers to the inability to maintain heart rate to meet metabolic needs. And tachycardia bradycardia syndrome, which is a variant of sick sinus syndrome in which slow arrhythmias and fast rhythms alternate, often in the setting of atrial fibrillation. Sinus node disease is primarily a disease of the elderly, but it can affect all ages. The median annual incidence of complete AV block in patients with sinus node dysfunction is low, in the range of 0.6 to 2.1%. And therefore, progression to AV block in patients with pure sinus node disease is not extremely common. It is important to distinguish between asymptomatic physiologic bradycardia and pathologic bradycardia, particularly bradycardia that is symptomatic. So a correlation of symptoms and heart rate should be sought. This can be obtained through the use of wearable or implantable rhythm monitors. This slide shows one of the manifestations of sinus node dysfunction. This patient has sinus arrest. You can see a QRS where the P wave was probably cut off from the first beginning of the slide, followed by another sinus beat, followed by absence of any P waves for an extended period of time. This represents sinus arrest, and it could either be sinus exit block or pure sinus node arrest. The invasive electrophysiology study and sinus node dysfunction or the invasive electrophysiology study in the evaluation of sinus node dysfunction has limited utility. However, when an invasive electrophysiology study is performed, the intrinsic heart rate can be sought by looking at the sinus rate after autonomic blockade. And failure to increase the heart rate above 100 beats per minute with autonomic blockade suggests intrinsic sinus node dysfunction. The sinus node recovery time can also be measured, and this is obtained by looking at the sinus return cycle length after overdrive pacing. So the heart is paced for an extended period of time, and the pacing is then abruptly stopped, and normally the sinus node recovery time should be less than or equal to 525 milliseconds when corrected for the sinus rate. Once again, the electrophysiology study for sinus node dysfunction is of limited value. Indications for pacing in sinus node dysfunction are displayed on this slide. As you will see, in patients with sinus node dysfunction, the correlation between symptoms and the bradycardia is highly relevant in deciding which patients have pathologic sinus node dysfunction that may necessitate the pacemaker. Class 1 indications include patients with symptomatic sinus bradycardia, including symptomatic pauses, symptomatic chronotropic incompetence, and symptomatic bradycardia due to required drug therapy. In patients with a heart rate less than 40 when a clear association with symptoms and bradycardia is not documented, this is a Class 2A indication, in addition to syncope of unexplained origin and clinically significant sinus node abnormalities found at EP study. Minimally symptomatic patients with chronic heart rates less than 40 while awake have a Class 2B indication, and a pacemaker can be considered. And in patients with sinus node dysfunction who are asymptomatic and symptomatic bradycardia due to non-essential drug therapy, a pacemaker is not indicated and may be detrimental. Moving down further in the conduction system, classification of atrioventricular block can be broken down into three categories: first degree AV block, second degree, and third degree AV block. In first degree AV block, all atrial impulses are conducted to the ventricles. The PR interval is prolonged, and atrioventricular delay usually occurs within the level of the AV node. In second degree AV block, intermittent failure of conduction between the atrium and ventricles occurs. There are two subtypes. Type 1, Mobitz 1 or Wenckebach block, involves progressive prolongation of the PR interval until loss of conduction occurs. This type of AV block typically is occurring in the level of the AV node. In type 2, or Mobitz 2 AV block, a fixed PR interval precedes the loss of conduction. QRS widening is typically associated with this type of block, and this type of block typically results from either infrahisian or intrahisian conduction abnormality and has a higher risk of progression to complete heart block and asystole. And finally, third degree AV block or complete heart block involves complete interruption of conduction between the atria and the ventricles. The prognosis in AV block is determined by the level of block within the conduction system. Intrahisian or infrahisian block is associated with a worse prognosis, and permanent pacing should be offered. Block that is solely at the level of the AV node is a more stable type of AV block. It can improve with exercise, improve with adrenergic tone, and this type of block, in the absence of symptoms, does not warrant a pacemaker. Infranodal conduction disease may become more apparent with exercise because below the level of the AV node, conduction is an all or none phenomenon. So when this part of the conduction system, the intrahisian or infrahisian conduction system, is diseased, higher atrial rates will not be able to conduct one-to-one to the ventricles. Therefore, patients who have atrioventricular conduction abnormalities such that they have exercise-induced heart block that is not related to ischemia have evidence of severe His-Purkinje disease, and a pacemaker is indicated in these patients. Mobitz 1 heart block, also second degree type 1 heart block, therefore involves progressive prolongation of the PR interval until block of AV conduction occurs. One can look at the PR interval in the return cycle length, the beat just after the dropped beat, and compare that to the beat just before the drop beat, and you can see typically the greatest difference between AV conduction and such that the diagnosis of Wenckebach or Mobitz 1 AV block is more evident. As mentioned earlier, block usually occurs at the level of the AV node. Block patterns in Mobitz 1 block can vary from 2-to-1 to much longer. Grouped beating is commonly seen. This type of block may improve with exercise, and Mobitz 1 AV block is often asymptomatic and typically has a benign prognosis and does not require treatment. This slide shows a patient with Mobitz 1 AV block. In the the three tracings at the bottom of the screen, these tracings show a continuous electrogram. One can see the PR interval gradually lengthening and then followed by a drop beat. You can also see that in the PR interval on the return cycle length just after the drop beat, compared to the PR interval just before the drop beat, there is the greatest discrepancy of PR prolongation and difference. And sometimes it is helpful to make this comparison if the diagnosis of Mobitz 1 AV block is not entirely certain. Also note grouped beating. You see a group here, and in Mobitz 1 AV block, group beating is typically present. So even from afar, one can look at this EKG and suspect Mobitz 1 AV block simply from the group beating pattern. In Mobitz 2 AV block, instead of having PR prolongation prior to the drop beat, or progressive PR prolongation as we see in Mobitz 1 AV block, the PR interval is fixed with intermittent failure of conduction from atria to ventricles. And the PR interval in the return cycle length is the same as the last PR before the block beat. Mobitz 2 AV block reflects disease at the level of the His-Purkinje system and below. Block patterns once again can vary from 2 to 1 or much longer. And because conduction in the intra and infrahisian conduction system is an all or none phenomenon, sometimes slowing of the sinus rate actually improves the ratio of AV conduction because more time is allotted for each beat to get through from the last beat. So anything that slows the sinus rate, such as increased parasympathetic tone or possibly even carotid sinus massage, can slow the rate such that the conduction ratio actually improves. And at higher rates, conduction is worse. Progression to syncope and more advanced heart disease, more advanced heart block is common in this situation. And in patients with second degree Mobitz type 2 AV block, a pacemaker should be offered. Complete heart block involves complete lack of conduction between atria and ventricles. It is important to note that in order to diagnose complete heart block, the ventricular rate needs to be slower than the sinus rate. If the ventricular rate is faster than the sinus rate and there is AV dissociation, this could simply represent accelerated ventricular rhythm or accelerated junctional rhythm, and conduction between the atrium and ventricle could be normal in these situations. A regular escape rhythm typically occurs that can either be junctional or ventricular in origin in patients with complete heart block. And when patients have a wider escape rhythm, this implies an escape in the conduction area or in the ventricles lower in the conduction system or in ventricular myocardial tissue. And this is a less reliable escape rhythm associated with a higher risk of asystole. This slide shows an example of complete heart block. The P waves march out, and the P to P interval is shorter than the R to R interval. And one can see as you go through the electrogram tracings on the bottom 3 continuous rhythm strips that AV dissociation is present. Indications for pacing in patients with AV block are shown on this slide. Complete heart block or advanced second degree heart block with bradycardia and symptoms, ventricular arrhythmias due to block, pauses of greater than 3 seconds, heart rate less than 40, widened QRS in the absence of symptoms, and atrial fibrillation with pauses greater than 5 seconds in the absence of symptoms, prior AV node ablation, and second or third degree AV block with exercise without ischemia are all class 1 indications for AV block. Complete heart block with a heart rate greater than 40 is a class 2A indication, and any level of AV block in neuromuscular disease is a class 2B indication. An AV block in the setting of drug toxicity that may not resolve is also a class 2B indication. And finally, asymptomatic Mobitz 1 AV block is not an indication for a pacemaker. And AV block that is expected to resolve is also not an indication for a permanent pacemaker. And we will see selective examples of this at the end of this discussion. We will now talk about unique situations in conduction abnormalities. This slide shows a continuous rhythm strip in a patient with alternating bundle branch block. This patient has intact AV conduction, but the QRS is wide and the axis shifts dramatically from a right bundle to a left bundle in lead V1. In patients with alternating bundle branch block, this finding suggests disease at or below the AV node, or correction, at or below the His-Purkinje conduction system, and the permanent pacing is indicated due to an increased future risk of progression of heart block and asystole. This slide shows a patient with a inferior ST elevation myocardial infarction, looking at leads 2, 3, and AVF, and associated complete heart block. The P waves march out and are more rapid than the QRS. In patients with inferior myocardial infarction complicated by heart block, this type of heart block can resolve over time with treatment and observation, and therefore a permanent pacemaker is not immediately indicated in this situation. The prognosis of complete heart block with a narrow QRS in the setting of an inferior myocardial infarction will often resolve with supportive care within a few weeks. In contrast, infranodal conduction disease after myocardial infarction is associated with extensive permanent damage, and permanent pacing is necessary. Lyme disease is another unique situation in which complete heart block does not necessitate an immediate permanent pacemaker. Cardiovascular manifestations of Lyme disease often occur within 21 days of exposure. Lyme disease affecting the conduction system typically manifests as AV block, either first, second, or third degree, often with a narrow QRS complex escape when it is third degree AV block. Effective antibiotic treatment of the Lyme disease is often associated with resolution of AV block. Some patients with vasovagal syncope have coincident sinus arrest during these episodes. Because vasovagal syncope can be associated with both a vasodepressor and a chronotropic response, a pacemaker may not be helpful in resolving symptoms. However, dual chamber pacing may be reasonable in a select population of patients greater than 40 years of age with recurrent syncope and documented pauses greater than or equal to 3 seconds in duration. And this is a class 2B indication. The caveat here, however, is that one would expect less benefit, even in this type of patient, when their syncope also has a significant vasodepressor component, which is often the case. Atrioventricular block and neuromuscular disease is also a unique situation. There are a number of neuromuscular diseases that may be associated with atrioventricular block, including myotonic muscular dystrophy, Kearns-Sayre syndrome, erg dystrophy, and peroneal muscular atrophy. Permanent pacing is indicated in third-degree or advanced second-degree AV block in these conditions, and it may also be considered for any AV block or bifascicular block in this setting due to the unique pathology of these diseases. We will now have a set of questions related to our discussion. Question 1. A 70-year-old female on no medication with moderate aortic sclerosis has intact AV conduction at baseline. During a treadmill test, she develops complete heart block at sinus rates greater than 110 beats per minute. That remains present until her heart rate slows. Coronary angiography is normal. Which of the following is true? A, the phenomenon likely represents conduction disease only at the level of the AV node. B, the His conduction abnormality is benign. C, carotid sinus massage will always worsen this conduction abnormality. Or D, a permanent pacemaker is indicated. Going through the results, A, going back to the question, this is a patient who has exercise-induced heart block in the absence of cardiac ischemia. This represents disease in the intrahischian or infrahischian conduction system, which is a high-risk situation for future complete heart block and asystole. Therefore, if we go through the possible choices, A is incorrect because this is not at the level solely of the AV node, and as we mentioned, is at the level of the intra or infrahischian conduction system. B is incorrect because this conduction abnormality is not benign. C is incorrect. Carotid sinus massage may actually slow the sinus rate and improve the ratio of conduction. And finally, D is the answer because, as we mentioned, this is a high-risk situation where progression to complete heart block and asystole is increased in incidence. Question number 2. In Mobitz type 2 AV block, carotid sinus massage may improve the number of conducted beats. B, a pacemaker is rarely indicated. C, the HV interval would be expected to be normal. And D, the risk of progression to asystole is lower than with Mobitz 1 AV block. In this question, the answer is A. We discussed in the previous slide the mechanism of carotid sinus massage and how it may improve the number of conducted beats if it slows sinus rate. A pacemaker is indicated in this situation, so B is incorrect. The HV interval would be expected to be abnormal in this situation, so C is incorrect. And D is also incorrect because the opposite is true. Question number 3. Which of the following is not a consideration for a pacemaker? Symptomatic chronotropic incompetence, A. B, symptomatic sinus bradycardia. C, sinus bradycardia that is asymptomatic with a heart rate of 42 beats per minute. Or D, syncope with chronic bifascicular block without documentation of bradycardia or AV block. Here the answer is C. Once again, in patients with sinus node dysfunction, the correlation between symptoms and the bradycardia have an important role in determining who needs a pacemaker. Therefore, A and B both involve symptomatic bradycardia patients, and a pacemaker would be a reasonable option. In the asymptomatic patient who simply has sinus bradycardia in the 40s, a pacemaker is not indicated. And finally, in the patient with syncope and bifascicular block without documentation of bradycardia or AV block, it is not clear that a pacemaker is indicated. In summary, sinus node dysfunction typically requires some degree of symptoms to fulfill Class 1 criteria for a pacemaker. The outcome of AV block depends on the location of AV block in the conduction system, and it is important to recognize unique situations such as myocardial infarction, Lyme disease, neuromuscular disease, where management of heart block may differ.